So as we discussed, there are four parts of parietal pleura. The first part is the cervical pleura, which covers the apex of the lung. And as it is a inverted cup-shaped dome over the apex of the lung, it is also called pleural cupola. So here we can observe that this part of the pleura will extend into the root of the lung 2 to 3 centimeter above the medial 1/3 of clavicle. So its highest point is above the clavicle 2 to 3 centimeter. And it is almost 5 centimeter above the first rib. Then we have already discussed that it is covered by the substance fascia or suprapleural membrane, which is a thickened, dense connective tissue layer, modification of endothoracic fascia, continuation of endothoracic fascia in the root of the lung over the parietal pleura. And the substance fascia is attached posteriorly on the transverse process of C7 vertebrae and anteriorly on the inner border of the first rib. On the lateral aspect of the thoracic cavity and the inner side of the thoracic wall, this cervical pleura is continued as costal pleura. The costal pleura is lining the inner side of the sternum, the ribs, costal cartilages and intercostal spaces, and also the sides of vertebrae. And we have already observed that it is separated from the thoracic wall by endothoracic fascia, which is a loose connective tissue layer. On the medial side, the cervical pleura and the costal pleura on the anterior and posterior side is reflected as mediastinal pleura, which can be identified by this sleeve-like structure, which is going to extend over the root of the lung, and this is called pleural sleeve. And the lower parietal pleural extension also extending below the root of the lung, which is called pleural ligament. So we can identify the mediastinal surface by this here. And then inferiorly, the costal and mediastinal surface are continuous with the diaphragmatic part of the parietal pleura. So we have already observed that mediastinal pleura is going to make the lateral limit of the mediastinum, and at the hilum, the mediastinal part of the parietal pleura is continuous with the visceral pleura. And here at the hilum, the visceral pleura is going to line the structures passing through the hilum of the lung, and the parietal pleura is going to make the pleural sleeve and pleural ligament. So we'll discuss the importance of these structures when we discuss the hilum of lung. Then the diaphragmatic pleura, we can observe here that it is lining the superior surface of the diaphragm and making the same convex curvature as the dome of the diaphragm. It is lining the diaphragm along all of its superior surface, except where here it is attached to the costal margin. So here the parietal pleura is reflected at costal pleura, and in the center where the diaphragm is fused with the pericardium, the parietal pleura is again reflected as the mediastinal pleura. Previously, we observed that phrenicopleural fascia is going to separate diaphragm and the diaphragmatic part of the parietal pleura. The pleural cavity is a capillary thin layer which is going to separate the parietal and visceral pleura. They are sticking by the pleural fluid, and there is capillary thin layer, so the fluid is moving in the pleural cavity. And as there is a slight negative intrathoracic pressure always, and there is surface tension of that pleural fluid, these layers are close together, except in some areas where here you can observe that when the parietal pleura, the costal part anteriorly is reflected on the mediastinal surface, the distance between the visceral and parietal pleura is slightly increased, but still it is a thin slit, and this part is called costomediastinal recess. This is an extra pocket of pleural cavity anteriorly. The more prominent one is the inferior one, which is between the diaphragmatic part and costal part of parietal pleura. Here you can observe that this is the costodiaphragmatic recess, and it is well observed as compared to the costomediastinal recess. Now these recesses can be properly observed during expiration, as when there is inspiration, the lung expands and occupies these recesses. So these are providing extra space. When the lung has to expand, these costomediastinal and costodiaphragmatic recesses, they are occupied. So they give the space for the spongy lung to expand. Also, we can observe that on the left side, as the cardiac notch present on the anterior border of the lung is more prominent as compared to the cardiac notch formed by the parietal pleura here. So we have this part of the costomediastinal recess, which is wider as compared to the rest of the costomediastinal recess and the costomediastinal recess of the right lung. So basically these spaces are providing extra space, and especially in clinical condition when there is accumulation of extra fluid or blood in case of trauma or pus collection in case of infection, the fluid is collected in these potential areas, and especially the costodiaphragmatic recess in erect position due to gravity. Pleural reflections are the line where the parietal pleura of one surface is abruptly reflected onto another surface. For example, costal pleura is reflected onto the mediastinal pleura anteriorly and posteriorly, and then inferiorly it is reflected onto the diaphragmatic pleura, and superiorly it continues over the cervical pleura. 3 lines of reflections are observed in both lungs. The important thing to remember is that these lines are not same on both lungs, as the heart is deviated more towards the left side. So, and there is also cardiac notch present. So these line of reflections are different on both sides. Now the first line of reflection on both lungs we are going to observe is the sternal line. Here you can see the right and left sternal line of reflections, and you can also observe that they are starting from cervical pleura here, tracing downward. They reach obliquely towards the second costal cartilage. From here the right and left sternal lines will be different. The right sternal line will extend downwards straight up to the 6th costal cartilage, and it will be reflected as the diaphragmatic or costodiaphragmatic line of reflection. On the left side, you can observe that the sternal line from apex reaches the 2nd costal cartilage. From 2nd to 4th costal cartilage, it is a straight line, and then there is this cardiac notch. So the sternal line runs obliquely up to the 6th costal cartilage, from where it is continued over the costodiaphragmatic line of reflection. We can clearly observe that the sternal lines, they meet in the midline, separated by a small amount of fascia, from 2nd costal cartilage to 4th costal cartilage, from where the left sternal line is deviated, forming this notch. Now this is important because Due to the formation of this notch, this area where the fibrous pericardium comes to lie just behind the sternum, we have the bare area of pericardium. So when we do pericardiocentesis, we keep in mind the sternal lines, their reflection, and this bare area, so that we can approach the pericardial cavity without puncturing the parietal pleura. Tracing inferiorly from the right sternal line, we start from anterior midline, and the costodiaphragmatic line of reflection starts here, and then in the mid-clavicular line it lies at the level of 8th rib, and then here on the mid-axillary line it lies at the level of 10th rib. Posteriorly we can observe as the costodiaphragmatic line of refractions are all around the inferior border. So posteriorly the lower extent of the line of reflection is the 12th rib. The only difference on the left side is anterior part. The left costodiaphragmatic line of reflection does not start from anterior midline, it starts from almost mid-clavicular line because of the notched area, and then the rest of the extent is similar, like mid-clavicular line it is at the level of 8th rib, mid-axillary line it is at 10th rib, and posteriorly the extent is up to 12th rib. Now posteriorly, starting from the cervical part and going down up to the neck of the 12th rib, we can see the vertebral line of reflections, which are the reflection of parietal pleura just opposite to the visceral pleura lining the posterior border of the lung. So the vertebral line of reflection is going to line paravertebral region from T1 to T12 vertebrae. So inferiorly they are continuous with the costodiaphragmatic line of reflections, which can simply be called costal line of reflections. Here the two recesses can also be observed again. The recess formed at the sternal line of reflection is known as costomediastinal recess, and the recess formed here at costal line of reflection is known as costodiaphragmatic recess. Now with the reflections we can observe the extent of costodiaphragmatic recess. In mid-clavicular line this extends from 6th to 8th rib. In the mid-axillary line, the extent is from 8th to 10th rib, and posteriorly the extent is between the 10th and 12th rib. So this is between the costal line of reflection and the inferior border of lung. The simple rule to follow here is that the pleura will be supplied by the nerves, which are supplying the structures that it is lining. So visceral pleura is supplied by the nerves, which are also going to supply the tissue of the lungs. So there is a pulmonary plexus formed at the level of the root of lungs, and this pulmonary plexus is formed by parasympathetic and sympathetic nerve fibers. The parasympathetic nerve fibers are coming from vagus nerve, which is the 10th cranial nerve, and the sympathetic fibers are coming from the sympathetic ganglia from the paravertebral chain of sympathetic trunk. The ganglia T2 to T5 are basically participating in this plexus. Now, the effect of parasympathetic innervation would be the nerve supply of parietal pleura will be the structures which it is lining. So on the mediastinal aspect, as the phrenic nerve is supplying the fibrous pericardium, so it is also going to supply the mediastinal part of parietal pleura. And the costal pleura is supplied by the intercostal nerve, as is the peripheral part of the diaphragmatic pleura, which is also supplied by the intercostal nerve. And we also know that the peripheral part of diaphragm is also supplied by the intercostal nerve, the lower 6 intercostal nerves. Then the central part of the diaphragmatic pleura is supplied by the phrenic nerve, which is extending from the medial surface up to it. So we already know that the central tendon of the diaphragm, that part of the diaphragm is supplied by the phrenic nerves. Root values C3, C4, C5. And it is a branch of cervical plexus formed in the neck. Now, as the visceral pleura is supplied by autonomic nerve fibers, it is only sensitive to stretch, and the pain is dull visceral type, while the parietal pleura is supplied by the somatic nerves, and it is going to be sensitive to pain, pressure, touch, temperature, and the pain is also the sharp kind of pain, and it is also referred to the areas which are the dermatomes of the spinal nerves, which is supplying the part of the parietal pleura. Blood supply of parietal and visceral pleura is also congruent with the structures. These are lining. So parietal pleura is supplied by the intercostal, internal thoracic and musculophrenic vessels, while the visceral pleura is supplied by the bronchial vessels. And the details of these structures will be studied with the lung. Lymphatic drainage is also from parietal pleura into the intercostal and mediastinal and diaphragmatic lymph nodes according to the part they are draining, and from the visceral pleura they are drained into bronchopulmonary lymph nodes. We will also observe these with the lungs.